Welcome to the Feinberg School of Medicine Institute for Global Health virtual event. I've been fortunate to be your host for all 13 of these gatherings, all in person, until this year, when we have all had to navigate our lives around the coronavirus, maintaining distance and communicating virtually. I've also had the honor each year to share a video look at the work of the GHI, following Northwestern medical students who had the opportunity to broaden their education and outlook, using their skills in clinics in countries around the world. Now, again, the virus has stepped in, and it has changed the focus of our video this year. But in a way, that has allowed us to dramatically reveal the critical importance of an interdisciplinary global health institute, and to show you how Northwestern's institute in particular has become a major force in the world's global health community as a key contributor to the fight being waged against the pandemic. I must tell you, I was personally overwhelmed and impressed by the laser focus and immediate response by the Institute's brilliant teams of research and medical professionals who made the important game-changing contributions to understanding the virus. The Institute is now sharing with the world health community its own critical genomic research, as well as fill a supply chain, a more accurate and faster test, while also working with COVID programs on the ground in other countries. We'll be sharing all of this with you in a 30-minute mini documentary that's coming up on our program shortly, as well as an opportunity to have some of your COVID-19 questions answered by our Institute experts. But first, I extend the gratitude of the Institute for the generous support from all of our donors. Even though we couldn't be together for dinner at the Peninsula, several of you continued to donate as if we were still gathering together. So thank you very much. And now, some breaking news. The Institute is delighted to announce a recent philanthropic gift that established the first chair in the Institute. The John R. Flanagan Charitable Foundation has made a $3 million commitment to the Institute to establish the Dr. Robert L. Murphy Professorship in Emerging Infectious Disease. This professorship recognizes and celebrates the decades-long relationship between the late John Flanagan and Dr. Murphy. Mr. Flanagan was a Northwestern alumnus, receiving his MBA in 1958. He generously supported his alma mater for more than 40 years. When filled, the professorship will support the research priorities of a faculty member in the Center for Global Communicable and Emerging Infectious Diseases. Not just breaking news, but very good news for the mission of the Institute. And now, as always, it's my privilege to introduce my doctor and the Deputy Director of the Institute for Global Health, Dr. Robert Havey.
Thank you, Bill, and thanks to all of you for taking time to join us tonight as we present the work we've been doing over the past year at Northwestern's Institute for Global Health. Many of you have taken part in this annual tradition for years, so we know that our virtual event tonight will be a little different. But with the year we've all had, I think we're all getting used to things being different. For some background, the Institute for Global Health is a nonprofit institute at Northwestern University's Feinberg School of Medicine, which grew from the original GHI Global Health Initiative and the Center for Global Health. We have a strong team led by Dr. Robert Murphy, an internationally known expert in global health and infectious diseases. And we have several objectives. Medical education is one of our top priorities. We send our medical students and faculty to over 42 countries, enabling them to participate in a number of clinical and research global health activities. This exposure helps transform our students into expert and compassionate physicians, and it gives them a better understanding of the health challenges faced by so many. In addition, we're educating global health leaders for the future. Our training includes advanced degrees in public health and medical research, including master's and PhD programs, which are awarded to candidates both here and in low-resource countries. We are dedicated to improve medical access for people living in countries, many with average incomes less than $700 per year. Our programs help bring care and hope to people who were born into systems which have left them often ignored. And last but definitely not least, we're committed to promoting scientific discovery, funding impactful and innovative research into global health problems. Our focus on COVID tonight will highlight some of those efforts. As the world changes with alarming speed, the work we do now is more important than ever. We've already seen the results of previous infectious diseases like West Nile and Zika, Ebola, and SARS, all of which could have spread in a pandemic fashion just like COVID. We also know that non-infectious problems like heart disease, diabetes, cancer, and neurodegenerative disease still cause death and disability worldwide, and that these conditions disproportionately affect those in low and middle income countries. It remains a disappointing and dangerous reality that more than half of the nearly 8 billion people in the world today still have poor access to basic and essential health care. As the world's population grows, our work becomes even more challenging. A recent Lancet study projected a peak world population of 9.7 billion people by the middle of this century, just 30 years from now, with a possible growth to 13 billion by the end of this century. Most of the population expansion is projected to be in those very low and middle income countries which are already lacking in care. For example, Sub-Saharan Africa, which currently makes up about 13% of the world's population, is projected to account for 35% of the world's population by the end of this century. These types of changes in the world present challenges and opportunities. If sustainable solutions aren't found, emerging diseases like COVID could become regular events. The strain on the world economy will just increase, and the social stability of all societies will be critically challenged. If, however, we focus right now on all these issues and plan better systems and better treatments, the talent found in this expanding world population could contribute, not detract, from our goal of finding ways for everyone to live healthy and productive lives. The Global Health Institute at Northwestern is committed to make this happen. With all of this as background about the Institute's mission, tonight we will focus on the COVID pandemic and the role the Institute has played in the world effort against this virus. Many of us in healthcare have been working on this crisis since the first case appeared in the U.S. in late January. The early days were tough, even by the standards of veteran physicians. Those of us seeing patients had no idea how contagious or deadly that virus was. We approached every patient with a definite hesitation, knowing that this might be the patient who could infect not just ourselves, but someone in our families as well. With little proven treatments and an initial very high mortality rate, it was an especially difficult time. So many things have happened since those early days of the COVID pandemic. Science and technology have risen to the occasion. Progress is being made at a pace never before seen in history. As you'll see in our video this evening, the three-dimensional structure of the virus was unraveled right here at Northwestern just days after the RNA sequence was published. Other discoveries quickly followed. We hope to give you at least a small glimpse of our work, showing that a global pandemic requires a team effort. Bill Kurtis and Donna LaPietra have gone behind the scenes to help us tell the story, producing a beautiful video which highlights some of the Institute's work over this past year. After the video, Bill will be back to lead Dr. Rob Murphy, Executive Director of the Institute, and myself in a COVID question and answer session. that will give all of our viewers up-to-date information about the Institute and the pandemic. Stay tuned for all of that, but first, please enjoy this year's Kurtis LaPietra production.
Cape Town, South Africa. In January of 2020, the leadership of Northwestern's Institute for Global Health has gathered here to discuss progress on a critical development in global care, innovation in point-of-care testing. They gathered scientists from all over the world to find better ways to test for and treat common infectious diseases. With a lack of access to advanced medical facilities, the ability to test patients in their local neighborhoods and get rapid results is critical in decreasing the burden of disease in these poor populations. For the past 14 years, Northwestern's GHI and Institute for Global Health have been committed to educating their students and residents in global health problems, funding innovative research to find cures for diseases new and old, and helping bring desperately needed care to under-resourced populations around the world. They have understood that the world has changed dramatically, and even the past 20 years, so that more than ever before, health problems anywhere can quickly become health problems everywhere. That concept quickly became a reality as a new virus was emerging 8,000 miles away. On the streets of Wuhan City, you may find yourself torn between the old and the new, looking up at the towering skyscrapers, or around you on the ground at a bustling, almost primitive marketplace. With few safety precautions in place, this mix of live animals with human activity can become a breeding ground for unique viruses, and in this case, become the epicenter of a global pandemic on a scale not seen in over a century. Between November 17th and December 1st, 2019, the first victim of a new viral pneumonia was infected. Within 3 weeks, 60 more cases had sprung up. On December 28th, the source of this new virus was identified as a novel, never-before-seen member of the coronavirus family. It was named SARS-CoV-2, but became more commonly known as COVID-19. Within months, the virus spread around the world. On March 11th, it was officially declared a global pandemic.
This virus has pandemic potential.
In an effort to contain the spread of the virus, factories closed, highways emptied, businesses were left abandoned, hospitals became overrun. The burden on healthcare workers and scientists grew more intense every day. Drawing on decades of experience studying and managing global infectious diseases, the Institute for Global Health at Northwestern became an epicenter for scientific and medical breakthroughs in handling the virus.
The Institute for Global Health now has completely pivoted to working on the pandemic. There's really no way around that. This is a global phenomena. The United States is leading the countries in number of cases and numbers of deaths. We have pivoted essentially all of our research to focus on the pandemic.
We had a policy where we would approve research projects about 3 times a year. When COVID hit, we agreed at the leadership of the Institute that we would approve research projects on a weekly basis. It accelerated the work for all of us.
And we've been quite successful in doing this and building up our expertise here.
The first step in the overwhelming task of treating this global pandemic was to understand the structure of COVID-19. The Institute turned to the Center for Structural Genomics of Infectious Diseases to model and sequence the virus, led by Dr. Carla Satchel.
When the first announcement came out in early January of this new coronavirus, we were able to contact our officers at NIAID right away, and were able to get our hands on that sequence really within the 24 hours of when it became publicly available. And we started designing based on that gene structure to get proteins made really from the get-go. As things got worse, we began to realize that really the entire resources of the center should be put after this. And so in late January, we put together a large platform with the goal of really solving the structure of every protein of the coronavirus.
With the structure of the COVID-19 virus now defined, the center focused on identifying proteins in the virus, which could be targeted by drugs to stop the virus from replicating.
We've really focused on now just 2 proteins. There's a complex of proteins called NSP16 and NSP10, and these come together to modify the genome of the virus so that it can actually translate that RNA into proteins and make viral particles. We're working to design drugs to specifically inhibit this protein. There was no work done on this protein previously, so there was no template to work on, and so it's really a brand new de novo drug discovery platform. It's great to just come at it from so many different directions, right? So have every scientist coming forward with their own best idea. You don't know what's going to work, but ideally there should be something.
The groundbreaking work has international importance in fighting the COVID-19 pandemic.
We've done this under an open science platform. So all of the structures that we've solved, we've made publicly available. So we've impacted not only what we've done through our center, but we get contacted constantly by groups internationally that we can then help to get their programs going. So maybe it won't be us that ultimately gets the best drug, but maybe it'll be somebody else who used the structural information or the information that we provided them or the proteins we provided to them.
Tackling a health problem of this scale is not something that can be done by any one discipline alone. The ability of the Institute to foster collaborative efforts between departments proved key to accelerating our understanding and treatment of COVID-19. Dr. Ramon Lorenzo of Northwestern Center for Infectious Diseases has used funding from the Global Health Institute to study mutations in the COVID-19 virus, both here in Chicago and in Nigeria, looking for changes which have huge implications for drug and vaccine development. His work has focused on the genetic sequence of the COVID-19 variants found in different areas of the world.
What we wanted is to study the genetic variability of the virus and how the virus is spreading and what characteristics the epidemic has in Nigeria. And for that, we will be sequencing viruses in Nigeria, and then from those sequences, that is the genetic material of the virus, we can get a lot of information, not only understand the variability, the different variants of the virus, but also we can understand how the virus is moving, if it's increasing in certain areas.
In humans, it has taken millions of years for our genome to change by only 1%. But in RNA viruses like COVID-19, the gene sequence can change by 1% in as little as 1 week. Without constant molecular surveillance, those mutations could be missed, making our drugs and vaccines less effective.
So we need to understand if when the virus changes, if it's creating new variants that might have other properties, for example, higher severity or higher transmission rate or any other.
With a greater understanding of the virus itself, testing became a priority. But as we quickly learned, systems that we once took for granted could become strained and unreliable during a global shutdown. Something as simple as a testing swab could be a barrier for our ability to screen for the virus.
We had one simple problem that was incredible at the beginning. We didn't have enough cotton swabs. You know, in our usual exam rooms, we have swabs to check your throat, to check your nose. And overnight, the COVID testing people came in to all the clinics around the entire medical center and took every swab that existed.
The supply chain, I guess if you want to call it, was under threat around, April and May of this year because everyone needed these things, and that, that supply chain wasn't able to quickly scale up. So the hospital was interested in finding some way to mitigate that risk. We started talking about how we can help. What this machine can do, or what it can print, is highly detailed or high resolution solid parts. And we use these printers to make COVID-19 swabs. So this is one of the swabs, actually. So you can see that this is the part that collects the virus. This section right here at this break-off point is what would go into your test tube, printed upside down. So this point right here was actually what was attached to, and there was a grid, just 300 on here total. And we tested out different methods of printing. And once I had validated everything, we coordinated with the lab downtown, brought these machines there, set up the manufacturing line. Once that was all there and we hit print, and then 24 hours later, it's magically there. That was the eureka, like, hey, we can actually do this. There were 4 machines running about 300 each, and there was, that would give you about 1,200. Roughly, I think there was about 1,000 per day. That was about the yield. Again, this technology, its core strengths lie in that if I have a concept, I can realize this thing very quickly.
As we found new ways to solve the cotton swab problem, we still had a shortage of machines to do the actual COVID-19 tests. Dr. Elizabeth McNally, director of Northwestern Center for Genetic Medicine, responded to the call.
That, sort of fateful first weekend in March when we all realized the world was pretty much not looking the same anymore, there was a call saying, well, who has these particular machines for being able to do nucleic acid testing? They're called real-time PCR machines. And we had 2 of the ones the hospital was specifically looking for. It uses human samples, but it's also sometimes doing testing from animal samples. All different things come in. We actually had them both in the core facility. So that was really the genesis of, okay, we need to help out the hospital, and how can we do this? And yeah, it's one of the really great things about being at Northwestern, which is it is definitely a team effort here on how people approach problems. And we have some big problems right now, so we need a team effort.
While the many gears of Northwestern moved together to solve problems as they sprung up, the Institute was also working to identify solutions of the future, a better way to test and screen for this virus, and to ready ourselves for all the change set to come in the wake of COVID-19.
One of our big achievements that we've accomplished so far is to change the focus of our research to focus on the rapid acceleration of diagnostics for coronavirus. We are now part of a huge $1.8 billion NIH effort to make and evaluate innovative new diagnostic testing devices and assays that can be used.
Dr. Sally McFall, director of the Research Center for Innovation in Global Health Technology, has directed her biochemical expertise and point-of-care testing experience to develop a new test for COVID-19.
So a lot of people are getting tested now, and they don't get their result for 3 to 7 days. And especially in situations where maybe you don't have symptoms, but you were exposed to someone who did. You don't know whether you should be staying at home for 14 days or whether you can just go out to the grocery store. With a point-of-care test, you actually get the answer before you leave your appointment. So our test is unique in that a lot of the point-of-care tests are rapid, but they're not that sensitive, and they're not approved for use as screening people, asymptomatic people. But our test is as sensitive as the ones that they run in big labs. So the patient would initially remove the swab from the paper and take the specimen where you would take it up into your nose. And then the operator of the test would then put the swab into the sample chamber and break off the swab at the score point and then cap it. Then you would put it into the device like this. The instrument then is going to move the sample into this first chamber here. The virus will lyse. Then the instrument will remove the fluids and into this next chamber, and then the paramagnetic particles will bind to those probes and will wash the potential inhibiting components away, and then we'll move it into this PCR chamber, and fluorescence will be read to see whether the presence of the viral RNA or not. Because of COVID-19, it really focused us to work on only one disease and develop our technology using that as the system. But it can be applied to HIV, it can be applied to tuberculosis, hepatitis C, any infectious disease, and also potentially cancer. We can look for genetic differences that could be markers for cancer.
Although testing has greatly improved, the lack of testing in the early days of the pandemic left large gaps in our understanding of how many people had already been infected. Antibody tests were needed to identify who already had the virus. But how do we reach a large enough population to get a true sense of how widespread COVID has been, both in different populations, in the city, and around the world?
The normal way you would do this would be you would have actually your blood drawn. And as we all know, especially in the early phases of this, in the months of April and May and June, there were not a lot of people who wanted to come out. So the way a blood spot works is we send people this kit, and this is actually a little finger poker that comes with it. It has a sharp edge. You pull this off and you poke your finger, and it makes some drops of blood, which you put on what is basically a paper card, 5 drops of blood, put it back in the envelope and mail it back to us. And it's a way for people to participate in this really important research from the comfort of their home.
Understanding how many have already been infected in Chicago was important, but it is just as critical to learn about the scale of the pandemic in other areas of the world. Dr. Claudia Hawkins is using funds from an Institute Catalyzer Award to measure the incidence of COVID infections in healthcare workers in Tanzania, using the same dry blood spot technology used in Chicago.
My colleagues and I decided to apply for Catalyzer funding to conduct a study that measures antibody levels in healthcare workers who are considered the most at risk of COVID in these countries, to see what proportion of healthcare workers have been exposed to COVID. And I think we still don't know that in some countries, particularly Tanzania, where data is not collected on COVID in perhaps the most robust ways that are collected in other countries. Just looking really to see who has potentially been exposed and infected with COVID among that healthcare worker cohort, and so by measuring the antibodies, that gives us some idea of who might have acquired COVID in the past. A serologic study like this will give us some clue about how much the pandemic has affected communities, and particularly again those in those high-risk professions. Now, they may not be indicative of healthcare workers may not be indicative of perhaps how much it's impacted another community, like a rural community, that are not necessarily in that risk category. But I think it's helpful, especially in countries where routine surveillance data is just not well captured.
Dr. Mark Huffman is studying the same problem in Nigeria.
Trying to wrap your hands around the global pandemic is obviously very challenging given the limitations in testing, data accessibility, analytic capacity, those sorts of issues. I'm really excited about the work that we're doing with the University of Abuja in terms of evaluating the seroprevalence or antibody testing of frontline healthcare workers across 60 primary care facilities in the Federal Capital Territory of Nigeria. This dry blood spot-based test, so it just needs a drop of blood from a small finger stick. You don't need a phlebotomist or someone specially trained in measuring this, and you actually just put it on a filter paper and let it dry, and then it can be mailed and analyzed, which is happening right now. So this is a great demonstration of a simple technology that was developed at Northwestern. We can use this technology for a whole host of other things to get research closer to people where they live, work, and play. It doesn't always have to be that research is only conducted in the academic health center itself, but we, as the researchers, need to be going out into the field to meeting people where they are.
While we work to develop these technologies, there are still basic issues that stand in the way of adequate testing and treatment in many places around the world. Things we now take for granted, like masks and other personal protection equipment, can be in sore lack of supply, even for the people who need it most, those in direct contact with the virus.
So we're seeing the inequities within our health system and health systems all around the world being exposed because of COVID.
It's difficult enough to set up clinics and testing stations in a lot of these countries. But then what do you do once you get the samples? These countries don't have labs on site at their clinics. You have to deliver those samples to central labs, and how do you get them hundreds of miles through tough terrain?
One of the projects that we were focused on in Malawi was with an organization called Writers for Health. So Writers for Health is basically a transportation system in Malawi where they pick up laboratory specimens across the 600 plus HIV clinics in Malawi. And they transport those laboratory specimens to laboratories. And COVID hit on April 2nd, I think, is the first case in Malawi. You know, a lot of that work was going to come to a halt, namely because the motorbike couriers didn't have access to PPE. And so they weren't able to actually go into the health facilities to pick up samples because they couldn't protect themselves. And we asked ourselves, like, what can we do to help? And so the Institute was allowed us funding to provide that PPE to them and to continue not only collecting HIV and TB samples, but also to begin collecting COVID samples. And so without that GHI funding, we would actually have to halt not only our research, but actually good patient care. With COVID, we've all gotten a better understanding of the long delays that might occur between when you have a swab taken in your nose and when you might have a test result. Making that sample transportation system more efficient not only improves public health, but individual health.
Educating the public about the pandemic and ways to avoid the virus is taken for granted in places like the U.S. But in poor countries around the world, thousands of lives can be saved simply by educating the public about the virus and how to avoid it. The GHI funded these public service campaigns in countries like Liberia, one of the poorest countries in the world.
The GHI, through this Catalyzer Award, was able to help fund a patient awareness campaign about infection control and prevention that can be used more broadly as a platform in Liberia across private healthcare facilities.
The GHI also funded sites like the Snapper Hill Clinic in Liberia, enabling them to improve their technologies so that the clinic has grown from treating 30,000 patients a year to 60,000.
Our country has a lot of challenges. And these types of supports, it really impact people's lives. When you're able to give them the tools and the knowledge that they need to survive, where they wouldn't be able to get that, that's actually direct impact on someone's life.
Beyond just protecting our frontline workers, we can leverage our ever-growing technology systems to provide something even more important: data and information that can be used to provide more accurate monitoring and predictive health care than ever before.
What we've been working on as an engineering group and as a team and institute has been neonatal monitoring as well as pregnancy monitoring, so things very relevant in global health. But when the pandemic hit, we realized that this kind of technology is very useful and potentially very powerful in the context of COVID-19. Frontline healthcare workers in the global health setting, they're really important. There's a lot less nurses and doctors in low resource settings. And so when those individuals do get sick, it has a sort of snowball effect in terms of the healthcare system and its ability to respond and react in low resource settings. Essentially what this is an ICU on two soft, flexible, wearable patches. So this is the chest unit, and basically, a little little adhesive, you put it right here. And it gives you ECG or EKG, gives you heart rate, some measurement of arrhythmias. It also has a motion sensor that acts almost like a e-stethoscope, so it kind of captures not only breath sounds and breathing sounds, but also your respiratory rate and chest wall movement. We also use that to get cough count. The other one is our pulse oximeter, and basically it's, wraps around your finger just like this and gives your blood oxygenation. It has temperature as well. They also talk to each other, so they're friends, and that gives our ability to actually measure something called pulse arrival time. It's basically how fast blood is moving from here to the finger, and that actually is inversely related to blood pressure. So it gives you continuous wireless wearable blood pressure. These sensors can operate in several kind of cases. The first is in healthcare workers that may have gotten sick, right, and have confirmed testing to make sure that their vital signs don't suggest that they're getting worse, right? And then I think probably more exciting, right, is the ability to detect COVID-19 before you're symptomatic or before you even need or know that you need a test. That can help do a lot of things. First is making sure they get the right care, but then also making sure that they're isolated so they don't get other people infected, like other patients or their coworkers.
The onset of this epidemic has only exacerbated, not replaced, the health inequalities we already faced before it. As we have learned from a virus that went from first infection to global disaster in just a few months, we are an increasingly globalized society. And it is critical that we understand health issues with a full view of our planet. The COVID-19 pandemic has shown in the most stark and sobering way possible how small the world has become, how quickly problems from the far corners of the earth can reach our doorstep, and how critical it is for us to understand healthcare from a global perspective.
Although we're going to get over this pandemic, either by treatments, by vaccines, or whatever, better diagnostics, that is going to end. But the question is, when is the next epidemic or pandemic going to happen?
And if it wasn't for the building blocks of scientific discovery over the last 20 years to get us to this point, we would not have been ready for this pandemic like we are. We need to keep that going because there will be another pandemic, and we need better technology, better discovery to prepare us even better so we don't shut the whole world down when the next one breaks out.
The Institute for Global Health has taken up that mantle with this in mind. We all share life on this planet and are responsible for preserving it.
One of the things that I've been struck with in our approach to COVID is the concept of being on a rowing team. And we all have to row in the same direction. If we're not cooperating in a pandemic, when it is hard to do, there's a lot of finger pointing, there's a lot of blame, but if we're not rowing in the same direction, it's gonna be hard to get to our destination together.
It shows you what can happen when everybody gets together and we take the resources we have worldwide, the scientists drilling down on every facet of one condition, sharing their information with each other and building on that in record time.
While we have focused our efforts on the COVID-19 pandemic, we are continuing our mission of education, clinical care, and critical research to address all of the problems in healthcare occurring around the world. We are training the global health leaders of tomorrow, improving medical education for doctors in training today, and bringing care to places that remain trapped in the past, all the while pursuing our goals of research and scientific discovery as the answer to problems old and new. Our mission is more critical than ever. We face dark times, but with great minds, dedicated bodies, and an unbroken spirit, we are preparing for emerging threats. And with your help, our work can expand so we all can continue to make a world of difference.
That's the sort of program I'm happy to endorse, and I wholeheartedly encourage others to support the endowment of the Institute for Global Health, under the directorship of Dr. Robert Murphy, who has now become famous outside of the medical community as the WGN COVID-19 expert, as he says, in the early morning between traffic and the weather.
Thank you, Ann. But no one with us tonight needs to wait for the morning news to have some of their COVID-19 questions answered, because joining me is Dr. Robert Murphy, Executive Director of the Institute for Global Health, and Dr. Robert Havey. We've already received many of your questions, but you can still participate. Just use your Q&A feature on your Zoom. But let's get underway with the first question to Dr. Murphy. Doctor, hello.
Hello.
Can you update us on the availability of an adult vaccine?
Yeah, the first vaccines coming out will be for adults, not for children. That's a little delay. That's kind of controversial right now. But anyhow, it's expected that of the 4 most advanced vaccine products, that 1 or 2 are going to be approved, get EUA approval, emergency use authorization, sometime in 2020. So either the end of November, yeah, I mean, it could be literally in a couple weeks, or it could be in December. That's approval. That's not distribution. Distribution will start immediately after that. BARDA, one of the U.S. agencies, has already purchased hundreds of millions of doses from each of those 4 companies.
Wow.
So they're ready to go. But distributing the vaccine out into the population of 330 million, assume at least half are going to take it, and some of them require a booster dose, is going to take the entire year of 2021 to get it out. So they'll start with the vulnerable populations and the frontline workers and people at highest risk, like for people with diabetes and older people. And then it'll slowly roll out really to anybody who wants it. That's going to take months, many months.
And how will you do it?
Well,
military or?
They've already really basically, I wouldn't say contracted, because everybody, you know, the government is the government, but they will use a military type approach, because the military is the only sort of group that knows how to do these massive type distribution things. They've got the supply chain, they've got the people, they have the properties, they can really do it. So it'll be a military-assisted effort.
I hate to think of the lines for these.
Well, I hope there's lines, because I hope people will take the vaccine. First, we have to see that it works. We have to see all the data. You have to get all the experts to agree that this is the way to go, and then people should go.
Now, will children have a vaccine too?
So the American Association of Pediatrics, which is based here in Elk Grove Village, I think, has made some statements. Of course, they want a vaccine for children, but typically childhood vaccines are for something like this are done after the adults have shown that it's safe in adults. And then the pediatric studies come secondary. You know, in the middle of a pandemic, do you really want to wait that long? And there's been quotes such as pediatrics vaccine stuck in neutral. Maybe they should be a little bit more aggressive. But the point is, they're going to come, but it's going to come after the adult vaccine is approved.
Let me follow up a question with the Institute itself. When you're running at full capacity, how many faculty can you have?
So the Institute, if we can get fully funded, which we're talking in the order of $75 million, a typical institute cost, that most likely that would support at least 100 positions, either part-time or full-time, in our 5 different centers and 2 programs. And those people would be expected, they'd be academic people for the most part. They would be coming with grants that they already have and with associated people around them. So the number gets big pretty quickly. They're all not, you know, the academics, but they come with a whole coterie, laboratory technicians and whatever. And so we're talking hundreds, and they would generate over $100 million in research. Already, since COVID started, Northwestern has attracted 34 million in funding for COVID. I mean, it's incredible. I mean, we didn't even have this disease in the United States until February of the 2020. How we've attracted so much research money. It's really incredible, and it will just grow.
Dr. Havey, he makes it sound so easy to get that money as it rolls in. All you do is kind of guide it into the right place.
Well, money is never easy to generate. We all know that. We've been grateful for all the philanthropy, which has really gotten us a great kickstart to get the Institute going. And it does grow upon itself. You know, people say money follows money, and it really does. When they see what we accomplish and they see what we can do, we do hope it'll keep growing.
Yeah. Can we talk about transmission risk for COVID? It's an aerosol. I understand that. How long does it stay, and how far away should we get?
Well, you know, there are good data showing that for every 3 feet you're apart from somebody, your risk of getting COVID drops by 50%. So 3 feet, 6 feet, 9 feet, 12 feet, you really can't be too far away. The farther, the better. I was watching a soccer game with a mask on outside, and there was a grandpa on the field who kept wanting to talk to me this far away, and I kept stepping away. People need to get the message. Distance matters. Indoor aerosols are controversial right now. There's lots of data on what sort of filters you should have. We do follow CDC recommendation that you should have 6 to 12 air exchanges per hour. That keeps the environment somewhat safe as people move indoor for the winter. But distance matters whether you're outside or inside, and masking matters because this is human-to-human transmission primarily. You need a mask.
Now, I see a lot of masks out there, but are we still running behind?
We're way behind. They're really, at this point, we're in a crisis mode right now. At this point, there really has to be a mask mandate, either by the state or by the feds. It has already been modeled that if we had a mask mandate right now, 130,000 lives would be saved in the next 4 months. 130,000 people would not die if everybody just could wear a mask. I just don't understand why that's so hard for many people to do.
They did a mask mandate in Melbourne, Australia, and as of 3-4 weeks ago, there was a $1,000 fine if you were found without a mask on. As of 3 to 4 weeks ago, they were down in one day to 0 cases. Zero.
Yeah.
$1,000 fine.
Well, Taiwan, Hong Kong, Vietnam, you know, a variety of Asian countries, all with mask mandates have, and Vietnam being very poor, Hong Kong being very rich, Taiwan also wealthy, almost no cases. It's basically gone.
Wow. How long does it stay on the surface, the virus?
Oh, that's controversial, and it's important to pay attention to surfaces. I tell all my patients that this is transmitted human to human in a couple of ways. Airborne, you need a mask, you need distance. And then what I call self-inoculation, keep your hands away from your face. A lot of people are wearing gloves, but those gloves are going into their noses and their mouths and then touching a grocery cart and then going back onto their eye. You cannot self-inoculate yourself. Wash your hands, use sanitizer, keep your mask on, and any surface you touch, don't look at the cardboard versus the stainless steel and think one is safe and one isn't. That just doesn't make sense. You'll never get anywhere that way. Just don't touch your face.
Yeah. How long does it stay? Let's say on money, on doorknobs.
The good news is our view of what we're talking about is called environmental transmission. Environmental transmission from surfaces, doorknobs and stuff turns out to be a relatively minor cause in the spread of this. I mean, the simplest thing can kill this virus. Soap and water, 20 seconds. Any kind of disinfectant, anything you buy over the counter, all kills the virus. It's fragile in the environment. It is not fragile in the human. If you get it in you, you're infected.
Dr. Murphy, what changes in the Institute have you made as a result of COVID-19?
So most of the Institute's money, the funding for the Institute, is what we call extramural funding. It's from outside of the university system. It's mostly from the National Institutes for Health. We were told by the NIH, since we are also infectious disease kind of oriented at the Institute, to pivot to COVID research. So we put our stuff on hold, what we were doing. We didn't stop it. We continued, with Zoom meetings and distance type communications, and we kept our regular stuff going, which involves mostly HIV and tuberculosis. But internally, we switched to COVID. And we became part of several U.S. government programs, a lot of them directed by the NIH. The one I'm most involved in is called RADIX, and that stands for the Rapid Acceleration of Diagnostics for Coronavirus. Everybody's aware it's hard to get a test. It's even hard to get a test now in November compared to what it was in the winter and spring. And so we are assisting companies in developing products that can rapidly test people effectively, efficiently, and inexpensively is our goal. And the first couple of those products are just coming into the pipeline right now. So that's called RADIX. There's another program called ACTIVE, which is an acceleration in testing of therapeutics and vaccines. That's in the Infectious Disease Department, which is, of course, affiliated with the Institute. And they are testing multiple therapies and vaccines for COVID. So we completely pivoted to working on coronavirus.
Let's look at the broader picture. It seems to me that you were in the right place at the right time. The right place as an institute to handle exactly the problems that are coming our way every day.
Things did come together. If you think about the roots of the Center for Global Health, which Rob started and ran, and the GHI, which I started and ran, they had different missions, different infrastructures. Putting them together just exponentially increased our strength and really did prepare us for this moment.
And so you have faculty members, students who usually travel internationally. What are they going to do?
Well, medical education's been challenged by this pandemic. In the spring, the medical school at Northwestern and all over the country had to shut down clinical exposure of the medical students just for their own protection. They were students, they weren't physicians yet, they hadn't signed up to be exposed or to be at risk. But at Northwestern, we took advantage of that. We started a really aggressive, nationally renowned COVID monitoring program early into the pandemic, within the first week. And we had about 1,000 medical students who now were out of their clinics. They were the ones who get on the phone 18 hours a day, calling every patient who got tested, every patient who was positive, and calling them a couple times a day to see how they were doing, try to help keep them out of the hospital. So we pivoted that way and used our medical students in that fashion. We've had to, unfortunately, shut down student travel through our global health experiences temporarily because no one can travel. But medical education's picked back up. The students are back in the clinics. They're, of course, getting a unique experience with COVID that they are going to remember the rest of their careers, being part of the front line of a cutting edge, once in a century historically pandemic, maybe not once in a century going forward, but certainly once in a century. So medical education has been challenged, but risen to the occasion, innovated, figured out other ways to get the medical students involved, and now really is, I think, poised to enhance our development of our future physicians through this pandemic.
Can you give us an update on the COVID cases at Northwestern and the whole system?
Rob Murphy and I have talked about this during the summer. We both were a little bit hesitant to draw any conclusions in the summertime of why the cases were down so far. We didn't know if it was lack of exposure, if it was viral load because people were outside, mutations of the virus, as you saw in the video. We didn't know what it was, but clearly it didn't go away because the surge is incredible lately. At our minimum, Northwestern hospital system, all of the hospitals in the Northwestern system, had about 50 patients hospitalized in the middle of the summer with COVID. That number's up to 350 now, and that 300 patient rise has happened just in the last 2 weeks.
In 2 weeks, wow. Why?
Why? Well, everyone keeps comparing COVID to the flu. And the flu usually starts picking up in November and December and goes through the winter. So we were expecting the same thing to happen with COVID. Everyone, it's a respiratory transmission, whatever. Well, it came a month early. And we don't have that mask mandate. and it just spread. Every population out there, it spread. It spread in the schools, the universities, businesses, restaurants, bars, and you know, this thing grows exponentially. And so that's why we go from 50 to over 300, you know, in a matter of weeks. And this is happening everywhere in the United States except the Northeast, because they've had stricter mitigation efforts than we have. Ours are sort of, you know, halfway. Halfway doesn't work.
And that's a dilemma that seems so unusual. The business wants to get back to work. They want to make some money. They wanted jobs to be filled. And yet the medical profession is going out of their mind. Speaking of a crisis, that...
You know, you potentially could do both, have your businesses and protect people if you respect the virus.
Right.
Distancing, masking, changing the work environment, lots of remote work being done already anyway. You don't have to get everybody back into the office. And you just have to avoid crowds without masks. The masks do help. They make a difference. People have to believe it and buy into it. And I agree with Rob, we need a mask mandate.
What would you advise people who are a little afraid to go to the doctor's office to do?
Interestingly, if you really look at the seroprevalence data, you know, the United States is reporting about 10 million cases of COVID nationwide right now. It's probably really 30 to 40 million because of inadequate testing in the beginning. Today, still not perfect testing. That's a lot of people, but it's only 10% of the population, and that's what the seroprevalence data shows. If 10% of the population has COVID, Northwestern has looked at its own cases. We have 29,000 employees. We have 142 documented cases of COVID among our employees. That's less than 0.5%. So we're doing something right. All of our waiting rooms are distanced. We wipe down everything. As Dr. Murphy said, the virus is easy to kill if you're careful. Everybody wears a mask. Every staff of the 29,000 is mandated to wear a mask throughout work. I keep mine on for 16 hours a day. It gets a little annoying, but I do it. And we really believe that the doctor's office is safer than going to the grocery store because of the precautions. But we know how to fight the virus, and a lot of the public takes shortcuts. They take their mask off, they self-inoculate, they touch their faces. But in our offices, in our clinics, in our hospitals, the spread is just non-existent. We know how to protect people.
I mean, basically, the hospitals are some of the safest buildings in the state right now.
So come on down.
Yeah.
Are there any other health conditions that are exacerbated by COVID?
Well, you know, COVID's a tough virus, and a lot of people try to compare it to influenza. And they say, oh, it's just another flu, and people just have to get it enough and get herd immunity. You need 60% of the population with COVID to get herd immunity, at least. So that's important to remember when the naysayers say that only half the population is going to take the vaccine. Well, if half took the vaccine and 10%'s already had it, and we're at 60% immunity, that would be a big step towards controlling the pandemic. So that part's okay. We know there's a lot of problems that COVID causes in other systems of the body, and we learn that more every day. There was a shocking study done recently on about 25 college athletes who had COVID, and between 2 and 6 weeks after their infection, they did MRIs of their hearts. They found evidence of heart inflammation in healthy young people in 45% of that population. 45%. We don't know what it means. We don't know what it means for their long-term cardiac health, but it shows the virus doesn't just give you a sniffle. It doesn't just give you a little cough and cold. We also know that there's a literature coming out on, we call it post-acute COVID results. I saw a patient the other day who had COVID in June. It's now November. He still cannot smell. He can't smell anything. And we've got a whole set of data on the central nervous system and the neurologic manifestations of COVID and how long that lasts, even things like brain fog, energy, fatigue. So that's in terms of COVID. Non-COVID diseases we have to really pay attention to, because one of the risks of COVID is that people with other conditions stopped paying attention to it. Preventive services started to drop. Around the world, a lot of people stopped getting routine vaccines. We had a patient in April at Northwestern who was on the heart transplant list for a year. His heart came in. He turned it down because he was afraid to come into the hospital.
Oh, no.
So the public has to have confidence in the hospitals because we are safe. They have to take care of all their non-COVID related things to keep themselves healthy. And then we have to handle COVID at the same time.
Wow. So what is the role that the Institute can play in the fight against COVID?
Well, is two things. One is just trying to deal with the current situation of learning more about COVID, better diagnostics, better therapies, the typical university stuff. But the real issue is preventing the next pandemic. We had 1918, 600,000 Americans died, more servicemen in World War I died of the influenza than in combat, but it went away. 3 waves, gone. This will go away. Every pandemic goes away. SARS came, 2003, and then MERS came. And the Asians were more impacted than we were here. And they got serious about it, and they prepared for the next pandemic. And that's why the Asian countries are doing so much better than we are. Mask orders, everyone on the same page, big fines, that was Australia, big fines if you are not doing the masking. All that works. New Zealand has like almost no cases. China, even in their biggest cities, there's no more cases. They had they had an outbreak, 12 people in outbreak. They tested 9 million people in 1 week to track everybody. We can't even track the people getting infected today. There's too many. Impossible.
Well, one major problem is lack of leadership from the top.
Yeah, it's from the top, and we have to prepare for the next pandemic. There's going to be another pandemic, whether it's a coronavirus or some other virus, respiratory syncytial virus. All these viruses will mutate, and we're going to get it. So really, our core mission is to prevent the next pandemic.
Yeah.
And that's why we were very fortunate to get funding from the Flanagan Foundation to fund a full-time position in molecular epidemiology. This is the kind of people that go out there and find out how the virus is transmitting, not just blaming it on one country or another where it first gets discovered. I don't know if you remember with the old H1N1 epidemic, they were calling it the Mexican flu. The poor Mexicans, it came from California, and the Spanish flu in 1918 did not come from Spain. They were the only country not fighting, and they were reporting the cases. It had nothing to do with Spain. But anyway, we want to find out where these things are and deal with it at that level.
So we have Thanksgiving coming up, Christmas coming up. Should families get together to celebrate?
The message is no different today than it was in February or March. It's all about your bubble, your faith in the people you're going to gather with. You cannot extend the bubble and think that that shortcut for the sake of a holiday is going to be safe. A bubble's a bubble. If you trust where everybody's been, it's almost like you need to ask every person you're going to gather with, where have you been? Who have you been in contact with? How many of your kids are in school? Who do you know who's had it? You have to keep a small bubble. You don't have to say the holidays have to be 100% virtual. We're at the point, there's so much of this, you have to default to a mask mandate for sure, but individual responsibility at the individual level and the family level. They have to be responsible in fairness to themselves, their guests, their families, whoever's going to gather. They've got to be smart and responsible and don't take a chance.
Dr. Murphy, what about the major global health issues that you feel strongly about should be receiving additional attention outside of COVID?
Well, we still have an HIV pandemic that is growing. The number of new cases exceeds the number of deaths. It continues. It's still growing every year. HIV is still a worldwide problem.
Even when we think, oh, it's all gone away.
It is not over. We're still having tens of thousands of new cases a year in the United States. So AIDS is not going anywhere. TB still is the biggest infectious disease killer. It's a huge problem. Not that big of a problem in the United States, but if you travel, it can be a big problem, particularly if you're in one of the lower middle income countries where it's more common. Malaria, we still haven't been able to get total control of malaria. And because of the pandemic, focus on those three terrible diseases are spinning out of control. The other thing is that, as Bob mentioned, and patients skipping the heart transplant or whatever, people are skipping all sorts of other visits to the doctor and procedures and diagnostics. The number of mammograms has gone down dramatically. That's all going to translate into something very bad later on. Globally, in the Institute, we have the one center is communicable and emerging infectious diseases, but we also have global oncology. We also have global cardiovascular health, global education, and global surgery, and programs in neurology and primary care. All those are really going to come into play. They're all going to be impacted by this pandemic. And so we're there, ready to go.
We also need to remember that half of the diseases or conditions worldwide that affect people and cause premature death and disability are not infectious diseases. So as important as it is to tool up for the other non-COVID infections, think of what we've learned in 10 months in terms of disease, epidemiology, immunology, virology, from going all in on COVID. Well, if we went all in on heart disease or all in on cancer, globally, the lessons we're going to learn will impact the next generation who has those diseases. Neurodegenerative diseases, Alzheimer's, Parkinson's, we're scratching the surface. It's really the next frontier outside of infections for medicine, and we're a long way away from good treatments and solutions. We can use the global stage to find those things out, in addition to our local populations.
Well, there's a foundation. How does the Institute plan to grow in this year and in 5 years?
Well, this year, we're still really wrapped up in coronavirus, and that's going to continue for us for at least the next year. But I think with the advent of the vaccines, a possible national mask mandate, or at least a state mandate for mask and social behavior changes, and then we're going to have better therapeutics. We haven't really discussed the therapeutics issue much, but this is an RNA virus that's very similar to other RNA viruses where we have very good treatment. It's like hepatitis C. And one of these treatments could transfer over and be a treatment for COVID. So you get a diagnosis of COVID, just like Tamiflu when you get the flu, and you might be able to eliminate a huge amount of morbidity and mortality with this kind of test and treat approach. First, we need a drug, all right? Remdesivir, the drug we use in the hospitalized patients with COVID, is an old Ebola drug, another RNA virus. So these drugs are out there, but we've got to find really potent ones that you can take orally, and that it'll be much easier distributing them than a vaccine. It'll be very complementary.
How has philanthropy helped the Institute achieve?
Well, the way it works in the United States is it all starts with philanthropy. There is nobody that's just going to give you $75 million to start an institute. I mean, no government agency or typically a foundation, something like that. It all starts with philanthropy. I mean, look at the Buffett Center. It went from the Buffett Center now to the Buffett Institute. You know, Roberta Buffett upped her ante and did it. The university is full of people who have given significant chunks either for institutes or for buildings where the institutes can thrive. So it's essential. The system is what it is, and it's really philanthropy that starts the whole thing. We can get these grants all we want, but we really can't grow to the next level without a significant philanthropic effort.
I mean, the irony is we wouldn't be sitting here today if it wasn't for philanthropy.
Right.
We wouldn't have gotten anywhere. This started, ironically, our two initiatives started almost at the same time 15 years ago and grew laterally alongside each other and came together. Now, we're really accomplishing great things. I think there's a lot to be proud of. Rob's done a great job as executive director. He's an internationally known talent. He's the guy to really take us to the next level. But we need more funding, for sure.
So it was a good idea.
It was a good idea.
Gentlemen, thank you very much. Fascinating. That's all we have time for tonight, but Dr. Murphy and Dr. Havey will review all the questions we could not get to, and there are a lot, and send a summary via email in the near future. Now let's get a final word from Dr. Havey.
It's our hope that all of you watching tonight can feel proud of what your support has produced. We are all very grateful. I've often said that you step up every year to help people you will never meet, who live in places you will never visit, all to help make a difference in the world. This year is a powerful example of things coming full circle, with COVID bringing all the global health issues discussed over the years right into our own homes. Some have compared the COVID pandemic and its effect on medicine to the effect World War II had on medicine and science, intending to show what can happen when the resources of this country and the world are focused on one enemy. During and after the war, the pace of scientific discoveries dramatically accelerated, creating medical treatments at a pace that would not have been possible without that international crisis. Just as the world joined together 75 years ago to fight a common enemy, so too has the pace of discovery accelerated today because of this world pandemic. Colleagues are joining together with us in every corner of the planet, working so that COVID-19, a household word unknown less than a year ago, will soon be in the history books. In its wake, the things we learn now will make us much more prepared for the next global health crisis, which we all know now could occur at any time. As I mentioned at the opening tonight, this has been a tough year for everyone. And unfortunately, with a recent dramatic surge in COVID cases, the pandemic is far from over. But there is reason to start to feel good again, since the work of so many has led us from the dark days we all felt just 10 months ago to the point where, even if we are not nearly at the end, your support has steadily brought us to the end of the beginning. Thanks once again for joining us tonight, and now I'll turn it back to Bill Kurtis to close.
We want to remind you one final time, if you wish to make a contribution, you can go online to our website, wewill.northwestern.edu/IGH Gala. Thank you all for joining us and for supporting the Institute for Global Health and the GHI. We also offer special appreciation to the generous members of our event host committee this year. Hope to see you all in person next year.